Assalamu alaikum. Welcome to the 20th Shaukat Khanum Cancer Symposium. We are at the last leg of our symposium today, and we had some exciting sessions. To begin with, this morning we had an amazing round of immense knowledge sharing through Asim Rashid medal competition, and I congratulate the people who had put their hard work in it, the mentors, the attendees, the colleagues. Thank you very much. At this point, I also want to take an opportunity to thank the organizers. You know, there's a famous saying that the only difference between a mob and a trained army is organizing skills. So I want to take this opportunity to thank Anika Agha, our colleague, our esteemed friend and colleague, Dr. Asad Parvez, for organizing and running this beautiful show for 3 days. We are at the last leg of this symposium, and I welcome you all to this exciting session of Gynae Oncology, where we're going to be listening to different talks today, and we're going to share some knowledge-based stuff. Unfortunately, one of my colleagues, Dr. Tabinda Sadaf, is out sick. She was supposed to help me out as a moderator. I wish her a quick recovery. I hope she's going to be back soon with health and happiness. I'm going to move towards starting this session now. I have my first talk from Dr. Asim Amjad. Asim Amjad, I'm very unfortunate to not get an opportunity to work with him as much as I would like to. While I was coming here at Shaukat Khanum, I haven't introduced myself yet. I'm Rehan bin Asif. I'm the consultant in Gynae Oncology, joined the department in 2019. So by the time I was joining the department, Asim Amjad was leaving for abroad. A great colleague. We had a brief intro, and during that brief intro, I found him very, very nice. And, you know, the guy who's interested in sharing knowledge. He is in the University of Saskatchewan in Canada now, an expert in IMRT. He's going to be talking about image-guided radiotherapy and adoptive radiotherapy in cervix. Over to you, Asim.
Thank you for inviting me to Shaukat Khanum Memorial Cancer Symposium. I'm going to record on Zoom and then upload it for the viewers and the audience. And I apologize for any shortcomings that might happen. This is a learning process for me and hopefully would go well. The topic assigned to me by Tabinda is image-guided radiotherapy and adoptive image-guided treatment in cervix cancer. Image-guided radiotherapy is when we use imaging during our radiotherapy treatment, which would improve the precision and accuracy of the treatment delivery. The imaging could be fiducial markers, it could be ultrasound, a cone beam, CT, or other modalities. What it does is it increases the precision of treatment as our tumor volumes are decreasing every day. We are increasing the dose to the tumor. So it's very important that we are precise in our treatment, especially for the organic organs at risk around the desired volume. We also would shrink our volumes as the treatment progresses, especially in cervix brachytherapy, from first session of brachytherapy to the second and third and fourth, because the tumor is shrinking. Now we need to reduce our volumes accordingly, and it's called adoptive radiotherapy. By this, dose increment is possible, and we can reduce the dose to OARs, and also by IGRT and adoptive radiotherapy, we can also reduce the setup errors during treatment, which is very, very important. So are we getting better in treating cervix cancer these days? I think so. Despite advances in screening prevention, cervical cancer remains a significant source of morbidity. But effective treatment is possible. We can increase the dose, which has shown benefit. We can reduce the dose to organs at risk around our desired volume, which are usually bladder, sigmoid colon, rectum, and bones. And these opportunities help to improve our clinical results. There are also surgical techniques improvement. We have improved our staging of the tumor by incorporating radiology more into precise stage of the cancer. External beam radiotherapy obviously has tremendously changed over last few years, and we are able to do a lot more precisely and with less morbidity. Brachytherapy techniques have improved. We do intracavitary and interstitial brachytherapy. We have adoptive radiotherapy, where we continuously shrink the volumes as the tumor progresses, and we image it quite well and draw our volumes with each imaging, which also helps us in delineating and obviously treating well. And chemotherapy, newer forms of chemotherapy have come up, which have also improved the outcome. This is a typical GRT workflow that we use at our institution. Patient, when comes for radiotherapy treatment and informed consent is taken, a lot of education happens for the patient before she gives the consent. Information is delivered by the physician, nurses, therapists, and other staff about a schedule, rationale, and outcomes with possible side effects. So once the consent is taken, we also use rectal preparation. If at the time of CT simulation, we see that the rectum is more than 4 centimeters, we tend to empty the rectum initially for first 5 days. 5 days before our CT simulation, we also do rectal preparation with oral medication. There's a bladder filling protocol, which for last couple of years we have started using, where we image with full and empty bladder to create an ITV. Patient is initially asked to empty the bladder, and then for 1 hour, we fill the bladder with about 300 to 500 mils of water. CT scan is done, and then patient goes, empties the bladder, and comes back, and another scan, CT scan is done with empty bladder. It helps us delineating an ITV with full and empty bladder. And because these are the two extreme variations that could happen. If the bladder is very full, it would move the bowels away from our desired volume. And when the bladder is not so full, it will cause those bowels to come closer to our target volume. So it gives a better understanding of how day-to-day variation could happen. We plan CT scan with full bladder as well. Second planning CT after emptying the bladder, as I said. 2 rigid plans are created with MRI and PET scan fusions, and we contour. Initial contour is done with artificial intelligence, where we have a software program which would outline the lymph nodes, the OARs, and other areas. And then it's second checked by the physician, adjusted the volumes if there's any discrepancy, and then it's peer reviewed as well. Second optimization and checking is done, and patient is then treated. This is the nomenclature that we use for outlining different structures, which is very similar to any other place. We use Embrace and TG263, which is AAPM nomenclature. Only thing in this slide is to remember that we do an ITV with full and empty bladder. And then our margins for PTV are about 7 to 10 millimeters superiorly. And then post, it's about 5 to 7 millimeters. These are the definitions of our OAR's contours: bladder, rectum, sigmoid bowel, femoral heads are the areas that we outline. And instead, obviously, because it's image-guided volume-based radiotherapy, we don't use point doses, we use the whole organ. This is our decision tree for using cone beam CT and when the matching needs to be adjusted or patient's position needs to be adjusted. It sounds and looks complicated, but it's simple enough to remember that we use bony matching. We have defined rotations of our bony margins, how much rotations we accept, and what is our PTV and OAR coverage volumes. If they do not fall into our predefined margins, then the radiation oncologist is called to the machine, and in combination with consultation with physicists, therapists, and ROs, we define what we need to do. Patient setup errors are taken seriously and avoided as much as possible by following this tree. This slide just shows us that we have come a long way from using portal imaging to VMAT and those increments which were not possible before. So IGRT is very, very important. Previously, it was a 4-field kind of situation where you would treat the whole pelvis to certain defined points from L4, 5 down to ischium and laterally covering the whole pelvis. So chances of miss were quite low, but we could not increase the doses by doing VMATs and being very narrow in our imaging and drawing the volumes. We can obviously increase the dose, but that means you have to be very careful for not missing anything. So IGRT, image-guided radiotherapy, is extremely important. This is a real-life imaging of a patient which we come across all the time, a large cervix tumor, obviously, with parametrial extension and pelvic lymph nodes on the left side. So this advanced tumor would have been difficult to treat with a very high dose previously. Now with our concise volume precision and able to increase the dose without causing too much damage to OARs, we are able to treat these. And as the time will go, this tumor will continuously shrink and we would have to adapt to the new environment and reduce our volumes accordingly, which will enhance the dose not only to the tumor, but reduces the dose to OARs, making it possible to take advantage by increasing the dose. And this is a plan for our VMAT plan for this patient. We would treat to a high dose, not only the cervix, but we are also able to give extra dose with external beam to the positive lymph nodes or the large lymph nodes. ASTRO, which is American Society of Radiation Oncologists, have come up with a clinical practice guideline, which was published a few months ago. This was developed in collaboration with American Brachytherapy Society and American Society of Gynecology, Oncology, and Clinical Oncology. And this was endorsed by ABS, CARO, which is the Canadian Association of Radiation Oncology, ASTRO, and Australia, New Zealand College of Radiologists, and Society of Gynecology, Oncology as well. They asked themselves 5 questions, and the 4 questions were related to external beam screening and other stuff, but I will go to the question 5, which was, patients who are receiving definite radiotherapy for cervical cancer, what is the optimal dose and fractionation schedule, imaging that you require, and technique for the delivery of brachytherapy? So the recommendation was that the optimal dose for definite radiotherapy for cervical cancer should be more than 80 gray or 8,000 centigrades in EQD2 fractions, and strength of recommendation was strong. There was also remarks saying that patients who had poor response or had a very large volume of disease, large volume being more than 4 centimeter, their D90 or coverage to 90% of the volume should be more than 8,500 centigrades. And it's reasonable, and it can be achieved by using hybrid intracavitary / interstitial technique, which can help improve the dose distribution for appropriate target coverage and OAR dose constraints when compared to intracavitary alone. So this is a good guide to know what doses you are aiming for. For OARs or organ at risks, their gold standard was that women treated with brachytherapy for intact cervical cancer, there should be volumetric contouring of OARs, and there should be use of appropriate dose constraints as recommended. That would be the gold standard. If that can't be achieved for whatever reason, resources, lack of resources, or something else, the 2D point-based dose constraints should be applied. So gold standard would be volumetric, but if that can't be achieved, then point A, point B doses could be considered with point doses for bladder and rectum. The key takeaway messages from these ASTRO guidelines were that radiotherapy is an essential and critical component of curative management of all stages of cervical cancer. When the disease is locally advanced, induction chemotherapy has not shown to be superior to this approach. But obviously, if the volume is too large and can't be covered, this could be considered, especially in Pakistan, where the disease is at much more advanced stage. And also additionally, adjuvant chemotherapy is under study, but it's not recommended at this time. This would be considered later. IMRT should be used as much as possible to reduce the acute and late side effects. Special care be taken to avoid undertreatment of target tissues. And so target motion and regular imaging on treatment are absolutely essential, which means IGRT is a very essential part of delivering radiotherapy. About brachytherapy, it was thought that it's an essential part of curative treatment of intact cervical cancer. SBRT and IMRT boosts were seen to be non-inferior techniques. But these techniques, compared to brachytherapy, run the risk of increased local recurrence and toxicity. Image-guided brachytherapy should be used to improve local control in the pelvis and to reduce the toxicity. And for image-guided brachytherapy, MRI was preferred and gold standard, but obviously MRI is not available in many centers, and it's not available for us either. So we use CT as an acceptable alternative. If volumetric doses are not possible, 0.8 planning remains an alternative. And other immunotherapy agents and new therapeutic classes of drugs are currently being explored. And ASTRO will update the guidelines on regular schedule based on the availability of these newer drugs. So this is the logarithm that they came up with for us in ASTRO. Locally advanced cervical cancer, initial external beam RT with concurrent cisplatin chemotherapy, brachytherapy boost, and applicator placement with image guidance, if at all possible. Treatment planning, volumetric dose specification is much more efficient rather than 2D 0.8 doses. But if not available, then that's a suitable alternative. And we aim, as we said before, for high-risk CTV to have a dose of more than 8,000. And if the volume are large, then those should be increased to 8,500 centigrade. And volumetric OAR dose constraints should be done. And thing to remember here is always prioritize high-risk CTV coverage. That's your prioritization. Those two OARs should be reduced as much as possible, but if possible, not to compromise your coverage to high-risk CTV. So these are the target volume definitions as per ASTRO, and GTV obviously at the time of brachytherapy is gross tumor present, and minimum dose coverage to that area is greater than 80 gray or 8,000 centigrades. High-risk CTV would include GTV, entire cervix, and regions that you see on T2 weighted images on MRI. And dose aim for this should be between 80 to 90 gray. Intermediate risk CTV should be high-risk CTV with an expansion, and there should be no expansion in OARs. And optimal dose to these areas is between 60 to 90 gray, as close to 90 gray as possible without increasing dose to OARs. These are the dose constraints guided by ASTRO, and we don't need to go into detail. We know that, and that's a conversation for another day. But these guidelines will help delineating our volumes defining the doses to these areas precisely. So this graph shows that there are 6 dose and volume groups here, which are defined according to the cut points of 85 to 95 gray. The different stages 1B, 2B, and 3B, and depending on what's the remnant volume at the time of brachytherapy, would determine what doses you should be trying to achieve for coverage. For instance, if you have a 30 cc volume and your disease coverage or the dose coverage to HR CTV is about 90 gray, 92% chance that 3-year survival would be, or actually local control will be achieved. But if you increase this dose to this 30 cc volume to roughly more than 90 grays, you can achieve a 95% 3 years local control. And similarly, if the volume increases more or is seen to be more at the time of brachytherapy. Your disease local control reduces quite a bit. So 30 cc seems to be the best optimal volume that can be controlled. Across the pond in Europe, there was similar effort done by IBS, GEC, Astro, and ABS was also involved in this for CT-based contouring and image-guided brachytherapy for cervical cancer. This was published only a couple of months ago in the Green Journal and was a very good effort to give us comprehensive guidelines for contouring when you have a CT-based imaging for brachytherapy. CT-based image-guided adoptive brachytherapy was used for guidelines was because there's a wide availability of CT scanners in radiation oncology departments. And there's a huge experience in its utilization for external beam and brachytherapy, obviously. One thing you have to remember is that when you compare CT with MRI for imaging, CT scan will overestimate the volume of the disease, which would volume and width of the disease, but it would underestimate the height towards the uterus. So slope in volume would be underestimated, but the total volume and the width would be overestimated. So what it tells you is probably that your coverage for HRCTV should have more margin and towards the uterus or superior inferior, and lateral and volumetric might be fine. Similarly, it continues to say that gold standard approach for contouring at the time of brachytherapy is MR at diagnosis and MR at brachytherapy with the applicator in place. But if that's not available, then MR should be done at the time of diagnosis, fused to your CT images to outline or delineate the volume of the disease. And just pre-brachytherapy, another MRI should be done to help you define your high-risk clinical target. What this guidelines tells us that uncertainties of CT planning can be reduced by very careful clinical and radiological examination. We have to keep in mind that the CT overestimates the lateral spread and underestimates the height, as we said before. So in order to make sure we reduce uncertainty, there should be bimanual examination, if possible EUA, and that should result into what we call a 3D clinical diagram, which would show your residual disease and disease at the time of diagnosis. And this was validated in the EMBRACE data. So clinical examination should be a very essential part of our description of the disease at the time of diagnosis and at the time of brachytherapy as well. And that's where if you need help with Gynae Oncology, they should be at hand to help with that clinical examination and outlining the diagram. Obviously, GTV intermediate, GTV residual, and CTV high risk should be documented. And in addition to this, a near maximum distance, which is the lateral spread of the disease, should be described as well. And this is the clinical diagram, and I think it is very useful. We are trying to incorporate that into our practice as well, where you document the lateral spread, the volume of the disease at the diagnosis and at residual, and with each brachytherapy session. So you know how to adopt your brachytherapy accordingly. And it's very helpful, I think, once you get used to it, and it's very simple to follow. For image-guided brachytherapy, for CT planning, we should have MRI at hand at the time of diagnosis and at the time of brachytherapy. Its accuracy is increased when taken at diagnosis compared to at the time of brachytherapy because of obvious chemotherapy and radiotherapy changes that might cause some discrepancy in outlining the tumor accurately. There should be a well-defined protocol for doing pelvic MRIs, which includes patient position, rectal coil, vaginal gel, bladder and rectal filling protocol, and T2, T1 images should be taken with contrast and non-contrast, axial, sagittal, and coronal images. 3 to 5 millimeter slice thicknesses should be used, and preferable 3 Tesla MR if at all possible. So they have come up with different categories of residual disease at each fraction of brachytherapy. So first category would be that there's no residual disease. There's nothing in the parametrium, nothing in the vagina or uterine, and no bladder or rectum involvement. And similarly, as we go down, residual disease present, proximal parametrial disease, and all that. So it's a good evaluation and description of how you should contour in each category is defined as well, which could be very helpful for any institution. And this then description tells for each case what you should draw. For instance, for cervix, there should be superior, inferior border, and thickness anterior and posteriorly, near maximum distance laterally for each category of the disease. So wherever your disease, residual disease forms, you should draw the volumes accordingly, and would help delineate consistently with each brachytherapy session. So this should be documented for each time then when the patient goes through the treatment. So this clinical diagram that I showed before should be used for each category that your disease might fall off for each brachytherapy session. For instance, in the first session, if the disease is coming up to the pelvic side wall, it should be drawn accordingly. This is the disease at the time of diagnosis, and at the time of brachytherapy, what is the disease extent and near maximum distance. It gives you better information how you could adapt your brachytherapy doses accordingly. So Embrace 2 adapted this clinical diagram and used it in combination with their radiological and clinical examination and outlined the tumor accordingly. So this has been validated. A good point to just to emphasize is that all our treatment, including external beam radiotherapy and brachytherapy, aim should be to finish the treatment within 50 days, if at all possible. And this slide emphasizes that 30 cc is kind of cut off. If your volume is more than 30 cc, you need to increase the dose. And by increasing the dose to CTV-HR by 10 grays, you could improve the survival. But then you need advanced adoptive brachytherapy for these. And that's what makes a difference. Embrace was a retrospective analysis of the Embrace data, which was used for image-guided adoptive radiotherapy. It was a multi-institutional database of 852 registered cases from 12 centers. It showed that image-guided brachytherapy combined with chemo-RT leads to excellent local control over survival and disease-free survival. Target volume at the time of image-guided adoptive radiotherapy and dose to CTV HR, D90 are clear predictors of outcome. So coverage is very, very important. If you are able to deliver 85 grays to D90 in 7 weeks, 3-year local control of 94% in limited disease, 93% in intermediate, and 86% in large sizes of more than 4 centimeters. And it does not cause significant late morbidity. So summary is for CT-based image-guided radiotherapy in cervix cancer is that minimum requirements are clinical examination and clinical diagram with documentation, CT or MRI imaging at diagnosis, at a minimum CT imaging with the applicator in place, and MRI at the time of brachytherapy as well. The recommendations are based on assessment of GTV at diagnosis and at the time of brachytherapy, categorizing the clinical response into different patterns that we discussed, defining various clinical radiological environments, and delineation and definition of target volume with the applicators in situ. CT-based contouring defines 4 remission categories aimed at improving the contouring accuracy for image-guided radiotherapy using CT MRI as available. At this point, due to time constraints, I will stop my presentation, and thank you very much for including me in the conference.
Thank you very much, Dr. Asim Amjad. That was a very fruitful input from a radiation standpoint in cervical cancer. And you know, cervical cancer is notoriously a disease of developing countries. And we see a lot of cervical cancer, especially the advanced cervical cancer, which is usually catered by chemoradiation. I'm going to move to my next presenter. My next presenter is Dr. Mia Muhammad Khurramshahzad. Khurram is based in Florida at Moffitt Cancer Center. Dr. Shahzad did his Gynae Oncology Fellowship from University of Wisconsin Medicine. He also holds a PhD in endocrine and reproductive physiology with special focus in cancer biology. He has also completed a master's in cancer biology and molecular carcinogenesis. He's been at Moffitt since 2013, and I'm proud that he's been contributing to our society ever since. He's been coming to Pakistan and delivering grand rounds and tumor boards, and I am happy that he's coming again in this coming January 2022, and we'll be happy to have him for citywide grand rounds in the last week of January at some point. The date will be announced soon. Over to Dr. Khurramshahzad.
Assalamu alaikum. Thank you for inviting me to present updates in cervical cancer management. I have no disclosures. Cervical cancer globally has a huge impact with over 600,000 new cases diagnosed worldwide, and mostly in low to middle income countries and middle to high income transitioning countries. The overall death toll for cervical cancer this year is estimated to be 341,831. That is staggering. As we all know, the HPV, the human papilloma virus, is found in almost all types of cervical cancer, especially the high risk types 16 and 18 is found most commonly. The HPV genome is a double-stranded circular DNA that is approximately 8,000 base pairs. And the HPV initially will infect the basal layer of the mucosa, and then over time with persistent disease will progress through the pre-cancer stages of CIN 1, 2, and 3, and finally cancer. This is a nice study of over 777 patients from Costa Rica, which essentially represents that most patients, when they are infected with HPV virus, they clear the virus in the first 2 years. That's between 70 to 80% of patients. And patients with persistent disease are those that then progress further from precancer stages 1, 2, 3 into invasive carcinoma. In this presentation today, I only have about 20 minutes, so I'm going to skim through the basic management and talk about the relevant updates. As we know, historically, for stage 1B1 cervical cancer, where the cancers are less than 4 centimeters, that's the old staging. With the newer staging, that's 1B2 cervical cancer. The surgical treatment is preferred over radiation therapy. This is the radical hysterectomy type 3. When you compare the survivals between radiation treatment and primary surgery, the survivals are quite similar. In patients who end up receiving both type of therapies, these are the poorly selected patients who underwent upfront radical surgery and then were noted to have high-risk disease. Either it was not tested and ignored upfront, or it was a surprise. These patients will end up receiving additional radiation treatment, thereby compromising their overall survival and substantial treatment-related side effects. Historically, we used to do radical hysterectomy abdominally. Then in the last decade, minimally invasive surgery came along, and with laparoscopic and robotic surgery, the type 3 radical hysterectomy was performed. Recently reported clinical trial by Ramirez et al. In 2018 was a non-inferiority trial with 631 patients. They divided these patients into 2 groups, minimally invasive surgery and open radical hysterectomy. Patients essentially who underwent minimally invasive surgery were mostly laparoscopic versus some patients had robotic surgery. Majority of these patients were outside of the United States, mostly in South America, and a significant number in Peru. This data generally does not reflect in my view, the US training. However, the results of this study do reflect that with minimally invasive approach, when we attempt to do a radical hysterectomy, the survival is approximately 10% less compared to the open approach, with the hazard ratio for death 3.74. So with this study, we went back to open radical hysterectomy instead of the minimally invasive technique. After the radical hysterectomy is performed, we generally divide the pathologic findings into low risk, intermediate risk, or high risk. Low risk patients generally do not require any additional treatment. Patients who are intermediate risk are those that meet the SEDLS criteria as presented historically in GOG 92. Once the patient meets the SEDLS criteria, these patients can be offered pelvic radiation treatment, as it was done in GOG 92 with a 47% reduction in the risk of recurrence. However, there is a significant added toxicity and no survival benefit. After this study, recently people thought that what if we add chemotherapy to this subset of high intermediate risk patients postoperatively who have undergone a radical abdominal or laparoscopic hysterectomy. These were the high intermediate risk patients with cervical cancer who either received external beam radiation therapy versus external beam radiation therapy and concurrent cisplatin for 6 cycles. And the idea was to see, does adding cisplatin to this subset of patients will improve their survival. This study actually was started in April of 2010 and is about to complete accruing in December of this year, and we're awaiting the data from this study. Patients who are deemed high risk, these are the patients who postoperatively are noted to have positive lymph nodes, positive margins, or positive parametria. These patients have much higher risk of recurrence and have overall poor survival. In these patients, the general thought is to looking at these significant historic trials, which I'm going to skim through, which you all are aware about, is adding cisplatin-based chemotherapy as per Peter's trial, which substantially reduced the hazard risk of death by 0.5, essentially cuts the hazard of death in half in these patients. The remaining trials listed here are additional 4 studies, which actually are in more advanced disease. These are the locally advanced disease patients with cervical cancer who receive upfront radiation treatment. In addition of chemotherapy, cisplatin-based chemotherapy can substantially add to their survival. After these 4 studies came out, the NCI went ahead and issued a landmark announcement to add cisplatin-based weekly chemotherapy to primary upfront radiation treatment. This kind of addition of chemotherapy is now the standard of care around the world and has been for a while, and leads to a 30 to 50% risk reduction in death when chemotherapy is added. Patients who have chemoradiation, they still have a significant risk of relapse and die from the development of distant metastatic disease. The Outback trial was designed to determine the effects of giving adjuvant chemotherapy after chemoradiation on survival. This is a GCIG international phase 3 trial with high risk disease, where patients with stage 1B node positive, 1B2, stage 2, 3B, or 4A, patients underwent radical hysterectomy and pelvic lymph node dissection. They were either noted to have positive pelvic lymph nodes or positive parametria, or para-aortic lymph nodes were positive. The primary endpoints of this study were overall survival at 5 years, and secondary endpoints were progression-free survival, adverse events, and patterns of recurrence. A lot of us were waiting for the Outback trial results, which are recently reported in an abstract, and we're awaiting the final publication. As per the abstract recently presented, the locally advanced cervical cancer here divided into cisplatin-based chemotherapy versus chemoradiation, followed by 4 cycles of carboplatin and paclitaxel. Again, this is classic standard chemoradiation arm versus chemoradiation, and at the end of completion, adding 4 additional cycles of carboplatin and paclitaxel. Overall, the key take points from this study are that at 5 years, the overall survival was quite comparable for those receiving additional adjuvant chemotherapy and those receiving standard of care. This was 72 versus 71% respectively. The patterns of disease recurrence were also very similar. In fact, there was a substantial difference in toxicity, especially grade 3 to 5 toxicity when you add additional chemotherapy at the end of chemoradiation. So as part of the abstract, our practice at this point has changed, where we are not offering additional chemotherapy after the completion of upfront chemoradiation treatment. Back in 2014, another landmark study introduced the anti-angiogenic therapy along with chemotherapy for patients with advanced or recurrent metastatic cervical cancer. They divided patients into 4 groups: cisplatin with paclitaxel, topotecan with paclitaxel, and then added bevacizumab to either of those 2 arms. What this study found here was that there was a significant overall survival benefit moving from 14 months to 17 months for patients with metastatic disease. The median follow-up of the study was 28 months. The median overall survival, as mentioned, went from 13.3 months to approximately 17 months, with a substantial reduction in hazard ratio for death to 0.71. Similarly, there was benefit in progression-free survival with overall response rate of 48%. The addition of bevacizumab in this study showed improved survival for patients with metastatic disease who are receiving this treatment upfront or in the recurrent setting, and this also changed the way we practiced chemotherapy for patients with metastatic disease. However, though there was a survival benefit, there is obviously a cost of giving cisplatin. Number 1 is the cost of the drug itself. Number 2, the hypertension, which is noted in about 25% of these patients, VTE about 8%, and GI fistulas in about 3%. Even though that study actually moved the bar, additional work in the last several years has been on immunotherapy. The role of immunotherapy in the development of cancer has been subject to ongoing clinical investigation in recent years. The emerging data here demonstrate that tumorigenesis result in ovarian, uterine, and cervical cancers is a consequence of impaired host immune responses to cancerous cells. Leveraging the immune system through the use of immune checkpoint inhibitors presents a profound opportunity to revolutionize the cancer treatment. In the state of chronic antigen presentation, such as malignancy, the chronic presence of antigen and pro-inflammatory cytokines like IL-12, interferon gamma can upregulate the PD-1 expression on T cells. The tumor clones can also select for PD-1 ligand expression. With PD-1 to PD-L1 binding, the peripheral exhaustion actually happens. The immune checkpoint inhibitors are proteins such as PD-L1 on tumor cells and PD-L1 on T cells, which are targeted. These proteins actually help keep immune responses in check. Some of the agents which are available to knock down these receptors are avelumab, atezolizumab, or durvalumab, which work on PD-L1 side. Others like nivolumab and pembrolizumab, they work on the PD-1 side on the T cells. From here on, I think the bar is further moving, looking at several studies, including Checkmate trial, keynotes that I will cover, and eventually the latest keynote study. Hopefully in the next 6 to 10 minutes, I will wind up discussing some of the therapies which are now landmark studies, which have very recently in the last month changed our practice for management of the metastatic cervical cancer. This is a depiction from the Checkmate 358 trial, which was phase 1 to 2, a trial which looked at the safety and efficacy of nivolumab monotherapy in recurrent or metastatic cervical, vaginal, or vulvar carcinomas. Here, it's interestingly a picture from a single patient who has disease in the mediastinal lymph nodes, subcarinal lymph nodes, and the lung and halar lymph node lesions. Over the course of 77 cycles, what that really means is how durable the response is here, that patients in a setting with 13 to 17 months survival in the setting of multiple previous chemotherapy is responding to such a long time to be able to receive 77 cycles of a particular immunotherapy. And you can see that from 2015 to 2017, those disease sites have almost or completely disappeared. This is a phase 1 to 2 trial with overall objective response rate of 26% and median overall survival of 21.9 months. NRG conducted a study around the same time using nivolumab in the phase 2 setting. Here, the NRG evaluated the activity of the single agent nivolumab in persistent or recurrent cervical cancer patients. 25 patients were evaluable for response rate or toxicity. The PD-L1 identified in 77.3% of tumor samples, 84% treatment-related adverse events, which were noted were mostly grade 1 to 2, 24% were grade 3. In this study, they found there was one confirmed partial response, and the duration of response was 3.8 months. However, the important part here is the stable disease, which was noted in 36% of patients, and the median duration of the stability of the disease was 5.7 months. I think that's the key point from this study. This is the overall progression-free and overall survival estimated at 16% and 78.4%. respectively. Waterfall plots show distribution of the best percentage change in the sum of the target lesion size from baseline for an individual patient. I will leave the study at this because I still have to cover quite a bit more. The next study that I wanted to discuss, which has been also recently presented in 2017, is the Keynote 28, which is the safety and efficacy of pembrolizumab, which is the PD-1 inhibitor in advanced PD-L1 positive cervical cancer. So phase 1b multi-cohort study, Keynote 28, it shows benefit of pembrolizumab in advanced, previously treated PD-L1 positive cervical cancer. Majority were squamous cell with metastatic disease, mostly to the lymph nodes, lungs, pelvis, liver, or bone. 96% of these patients had prior platinum and 42% had prior bevacizumab treatment. Toxicities are listed here that include rash, fever, diarrhea, and using the RECIST 1.1 criteria, the partial response rate was 17% and stable disease noted in 13%. Again, this is single agent pembrolizumab. This is the progression-free survival noted here. In conclusion, the results from the analysis of the phase 1b Keynote 28 trial suggest that pembrolizumab is well tolerated and has durable anti-tumor activity in patients with PD-L1 positive advanced cervical cancer. This then led to phase 2 trial of Keynote 158. Keynote 158 was presented in 2019, which looked at the efficacy and safety of pembrolizumab in previously treated advanced cervical cancer. This is a phase 2 basket study investigating the anti-tumor activity and safety of pembrolizumab in multiple cancer types. And the data here is specific to ovarian cancer. Patients received pembrolizumab 200 milligrams every 3 weeks for 2 years, or if there was disease progression or intolerable toxicity, or physician and patient decision was to actually get the patient off of this therapy. And they looked at objective response rate as the primary endpoint and the safety as the secondary endpoint. 98 patients were treated on this protocol. Median age was 46 years, and it ranged from 24 to 75. 65.3% of patients had ECOG performance status of 1. 82 patients, or 83.7%, had PD-L1 positive tumors. 77% having previously received 1 or more lines of therapy. Median follow-up was 10.2 months, and the objective overall response rate that's listed here was approximately 10.2 months with 3 complete and 9 partial responses. The all 12 partial responses were in patients with PD-L1 positive tumors for an objective response rate of 14.6%. And 14.3% of these responses were in those who had received 1 or more lines of chemotherapy for recurrent or metastatic disease. The median duration of response was not reached, and it ranged at the end of the study was between 3.7 to 18.6 months. And there were significant treatment-related side effects also noted in this study. Before I get to those, this is the progression-free and overall survival listed here, which is improved. Looking at these graphs, bear in mind this is a single agent pembrolizumab in a phase 2 study. Treatment-related adverse events occurred in 65.3% of patients, and most common were hypothyroidism, about 10.2%, decreased appetite in 9% of patients, fatigue in 9%, and treatment-related grade 3 to 4 adverse events occurred in about 12.2% of patients. These are the immune-mediated side effects listed here: hypothyroidism, colitis, hepatitis, pneumonitis in 1 patient. In summary, interim results from all 98 patients with previously treated advanced cervical cancer enrolled in Keynote 158 study and treated with pembrolizumab had an overall objective response rate of 12.2%, included 3 patients with complete response, and the rest of the findings that I have covered already. So this is overall an encouraging result from a phase 2 trial. This then led to the most recent publication, which is Keynote 826 with pembrolizumab for persistent, recurrent, or metastatic cervical cancer. I know I'm going over my time, but these are the 2 most recent studies. I would probably need another 5 minutes to actually wind up. Here, this is a double-blinded phase 3 clinical trial where patients were randomly assigned with persistent, recurrent, or metastatic cervical cancer in 1-to-1 ratio to receive pembrolizumab 200 milligrams intravenous every 3 weeks for up to 35 cycles, plus platinum-based chemotherapy, plus minus bevacizumab. So this study actually took the standard of care treatment, which was carboplatin, paclitaxel, and bevacizumab, and then added pembrolizumab as immunotherapy to that versus placebo. Trial profile is listed here and can be reviewed in the publication. To save time, I wanted to briefly mention that here we see a significant improvement in progression-free survival when you add immunotherapy like pembrolizumab with a substantial reduction in hazard of death with a very tight confidence interval and p-value of 0.001. This is a progression-free survival with PD-L1 combined positive score of greater than 10, and they see a better response in this set of patients. Overall, as you can see, most of the subgroup analyses do not cross the line here in the middle, which are actually statistically significant. When you look at the overall survival, this is where the study is actually making a difference here. Patients who had a CPS score of greater than 1 when they were offered pembrolizumab on top of carboplatin, paclitaxel plus minus Avastin, they had better overall survival with hazard ratio of 0.64. Patients who had scores of greater than 10, that's the CPS score greater than 10, they actually have not reached their median survival at the end of the study, and the study has gone all the way up to 30 months, which is very substantial. And due to this, you can see that the standard of care actually has changed in the last few weeks. These are some of the side effects which are expected from pembrolizumab. Moving on briefly to second-line treatment. There are a few effective second-line treatments which exist for women with recurrent or metastatic cervical cancer. Very recently, within the last few weeks, the second-line treatment as the first-line treatment for metastatic cervical cancer has changed. The second-line treatment has changed as well. This treatment essentially took patients with recurrent or metastatic cervical cancer and treated them with tisotumab vedotin, which is anti-tissue factor antibody drug conjugate in cervical cancer patients in a multi-center open label phase 2 single arms fashion. This is some of the details of the patients who were included. The squamous cell carcinoma patients were about 68%. Previously treated patients with cisplatin chemotherapy with radiation treatment were 54%. Previous lines of treatment, at least one line of previous treatment, 70%, 2 lines of previous treatment, about 30%. Any previous bevacizumab, almost 70% of patients had bevacizumab, and patients with medical history of ongoing peripheral neuropathy, approximately 20%. You can see the disease control rate here, which is very substantial, which is 72% with the addition of the tissue factor. Due to these results, with median overall survival of 12.1 months, which is very substantial in this group of patients with the second-line treatment, the accelerated approval based on this phase 2 INOVA TV204 trial with response rate of 24%, progression-free interval of 4 months, and the overall survival of 12 months has been given. And this really has changed our practice in the last 2 weeks. Yes, this drug combination has significant side effects, which include alopecia, epistaxis, nausea, conjunctivitis, but these are all manageable. Essentially, ophthalmology evaluation prior to each cycle is recommended, and if you follow the study protocol, patients will find that these side effects are quite tolerable given the efficacy of this therapy. Additional lines of treatment, briefly to mention, in chemotherapeutics, in recurrent or metastatic cervical cancer after the first 2 lines of therapy are listed here with response rates of about 26% at best for paclitaxel, doxorubicin 19%, topotecan, and bevacizumab. A lot is coming up. I think we are awaiting some of the other trials to show up in the near future, and hopefully I'll be able to present that data soon. Thank you so much for your time. I would be welcoming any questions that you have at the end of the symposium. Thank you.
Thank you very much, Dr. Shahzad, for this interesting presentation on innovations in cervical cancer. And obviously, you must have heard that innovation is the ability to see a change as an opportunity, not a threat. So we are taking these opportunities to change the scenario and the horizon of cervical cancer, which is a deadly disease, especially in the developing countries. I'm going to be moving on to my next speaker, who's Dr. Sadia Hassan Paul. She is a consultant gynecologist working for Dow Medical School in Karachi, Pakistan. She's an expert in her field, especially she's very passionate on cervical screening and vaccination in Pakistan. She is a leading figure in implementing guidelines through different organizations, especially Society of OBGYNs in Pakistan, and a great advocate for women's health. She has done multiple colposcopy workshops. She's a fellow for Royal College of Surgeons, OB-GYNs. She is a great person and a leader to improve women's health in Pakistan. Over to Dr. Sadia for the talk in cervical cancer screening and vaccination in Pakistan. Thank you.
Thank you for inviting me. So in August 2020, the 73rd World Health Assembly passed a resolution calling for the elimination of cervical cancer worldwide. The WHO officially launched the elimination strategy, setting goals for all countries to achieve by the year 2030, which is 90% HPV vaccination coverage, 70% screening coverage, and 90% access to treatment. So I'd like to start my presentation with the story of 2 Pakistani women. One is dead at 26 years of age. She was married for 4 years when she presented in emergency and had been getting fertility treatment for 2 years, no pap smears, and presented in emergency with acute pelvic pain and was diagnosed with stage 4 cervical cancer. She died very soon afterwards, and her photo to the right is shared with the permission of her family. The other is a 32-year-old para-2 who was in her second marriage. She's alive. She was diagnosed with CIN3 on a routine pap smear, and she underwent loop excision treatment under local anesthetic, and She, however, developed recurrent CIN3 a year later, underwent total abdominal hysterectomy, and was found to have cancer in situ with no invasion. So the message is cervical cancer is preventable. Safe sex using condoms, reduce the number of sexual partners, and polygamy, which is prevalent in Pakistan. You don't have to have 4 wives. One may be enough. And regular pap smears or HPV screening, and getting vaccinated. We have a vaccine for this. So, and do not smoke pan, gutka, and tobacco. This is very common in Pakistan, even amongst women, not just men. So this is a silent killer. It produces no symptoms until an advanced stage. And these are usually, once the cancer has started invading, abnormal bleeding between periods with intercourse, after menopause, unusual vaginal discharge, leg pain, pelvic pain, and in advanced, this is in advanced cases, and bleeding from the rectum or bladder. Now, the 10 most frequent cancers in the women worldwide, if you take the whole world, cervical cancer ranks number 3, and the more developed, in more developed regions, it is less common. However, in the less developed countries like Pakistan, it is more common, ranking 2nd or 3rd. So the estimated cervical cancer cases per year are over 530,000. And 85% of the burden of the disease is located in developing countries like Pakistan. It is the 2nd most common cancer in women in such countries, and younger women show a high burden of HPV-related cancer, with almost half the cases occurring before the age of 50 years. As I said, breast is, as we all know, the most common in Pakistan. The lip oral cavity, thanks to the overuse of tobacco and gutka and pan, especially in Sindh, is number 2, and cervix is number 3. However, the other thing is to note is the number of deaths, the death count due to cervical cancer. Pakistan is the 7th in the incidence in the top 10 countries. So what are the risk factors prevalent in Pakistan which promote cervical cancer development? These are low socioeconomic groups, smoking, tobacco, chewing, gutka, shisha, and multiple pregnancies, early marriage, sometimes even before puberty in the rural areas, high prevalence of infections, the number of sexual partners, as I mentioned, it isn't, we're not a monogamous society. Universal screening and is absent, and only opportunistic screening exists, mostly in private practice and in tertiary care hospitals. And the healthcare provider perception is also deficient, or let's say wrong, in this, that they think that this is not a common cancer. Low risk factors are race, and it's a Muslim majority country, and circumcision. So when we talk of prevention, there are really 3 phases. One is primary, secondary, or tertiary. And the primary prevention is before exposure. So vaccination comes here. Secondary is once the infected with HPV infection, the disease onset, then we need to detect it early. And once it is established, then detecting the signs and symptoms, and then going for early cure. Otherwise, she's heading for disability and death. So as I said, HPV vaccination is something which we can offer, and this should be before sexual debut, ideally, that is before exposure to HPV virus. And secondary comes in with HPV screening, which can be done with cervical cytology. We have both pap smears and liquid-based cytology available privately in Pakistan now. Visual inspection with acetic acid or VIA is a cheaper alternative to cervical cytology and can be done by trained doctors and nurses in their outpatients. So this is something we need to teach our postgraduate students and nurses all over Pakistan as an alternative to cervical cytology, which is both expensive and not being offered universally at the moment. Colposcopy and local excision of CIN lesions, we're really going into precancer stage or CIN, and this can be done very easily by trained healthcare providers by loop excision of the transformation zone of the cervix, by LEAP or LETS, and cryotherapy, knife cone biopsy, which is the traditional way. If you don't have these modalities, can be done with knife cone biopsy. And the last resort is hysterectomy. So how does a woman acquire HPV? Every sexually active woman is at risk of acquiring an oncogenic infection of HPV. 50 to 80% of women will acquire this infection in their lifetime, and 50% of those infections will be an oncogenic type of HPV. The risk starts from sexual debut and continues throughout life. So this is a virus which is actually very clever, the HPV virus. There are more than 100 types of it, and it's a very common infection. So the entire viral life cycle occurs within the epithelium of the cervix. There is no viremia, there is no cell death, no inflammation. There's local immunosuppression caused by the viral proteins. So as you can see, this is the basement membrane, this is the cervical epithelium, and this is the cervical canal at the top. And this is the virus. As it enters into the epithelium, goes down to the basal layer, and then it replicates within the cells, and more layers get involved. Eventually it gets excreted in the cervical canal. It doesn't enter the bloodstream. Hence, antibodies don't develop. And these are the subtypes of the papilloma virus. And the oncogenic ones, the most common are 16 and 18, which you can see highlighted in yellow, and 18, and the ones close to it are the ones which are also oncogenic. So vaccines have been developed, which are basically 3 which are at the moment being used. And the most latest one is the nonavalent vaccine, which covers 9 types of HPV. These two, the bivalent one and the quadrivalent one, were available in Pakistan, but not anymore. For the past 2 years, this vaccine is, it was available to the private patients, but not in the government hospitals. But now even that is gone. Now with I think the launch of the nonavalent, the focus has shifted to it, and most countries are giving that. And the girls and boys in some countries are being vaccinated from the age of 9 to 14 years. And you just need 2 shots then at 0 and 6 months, meaning 6 months apart. So school vaccination is a good idea, which is what is being done in most developed countries and our neighboring countries like UAE and other Muslim countries in whose EPI schedule it has been added. If you're vaccinating after 15 years, then you need 3 shots, 0, 2, and 6 months, just like Hpv vaccination. So we really need to get this vaccine in Pakistan. However, the HPV vaccination does not eliminate the need for screening and pap smears later in life for disease caused by other oncogenic HPV types. So we come to secondary prevention. This must be carried on at the same time. Remember that the disease progression is that if a woman has CIN1, 1/3 will revert to normal by its own, the body gets rid of it. In CIN2, 2/3 will progress to invasion in 10 to 20 years. It doesn't happen instantly. So you don't need to panic. You do have time to take care of the woman. What is the value of the cervical screening? Abnormal precancer cell changes found during screening can be monitored and, if necessary, treated before they progress to cervical cancer. The risk of developing cervical cancer is 3 to 10 times greater in women who are not regularly screened. So if you don't have the facility for pap smears or liquid-based cytology or HPV screening, VIA or visual inspection with acetic acid provides a very cheap alternative. And all we have to do is a speculum examination, apply some household vinegar, which is around 5% concentrated acetic acid. And that can be applied to the cervix, and abnormal areas stain aceto white. So this is something which should be taught to all gynae residents. And this is a very good alternative where we are doing nothing at the moment. So treatment options for CIN, once a woman does develop that, is if it's CIN1, you may do no treatment and just follow her up if that is what she wants. It may just treat itself. On the other hand, if you're worried that she will not come back for follow-up, it's better to treat. So local destructive therapy like diathermy, cryotherapy, laser we don't have in Pakistan, so we don't talk about it. It's too expensive as well. Loop excision like this diathermy loop, a thin wire attached to any diathermy pencil can be used for treatment, and it's very easy to learn. Knife bone biopsy if you have nothing else, and of course hysterectomy. So once a woman has developed invasive cervical cancer, it's very expensive, it's painful, it's traumatic, and radical hysterectomy and radiotherapy or combined radiotherapy. These are the options if caught early. But the sad thing is in Pakistan, they are mostly the women who develop cervical cancer, because they have not been screened, they present late and they end up with traumatic surgery. The family spends a lot of money, and mostly to places like Shaukat Khanum or advanced radiotherapy centers, which are a few in the major cities of Pakistan. So it's very, very expensive. So our government is being penny wise and pound foolish. Instead of focusing on public health measures like universal screening and vaccination, HPV vaccination, we're just treating advanced cancer. And the result is that they don't really get better. They eventually all die very soon. And the family spends a lot of money. So we have no universal screening at present. The HPV vaccine is not available anymore. The treatment is available only in the major cities of Pakistan. And we don't have an organized data collection. Our cancer registry is very, very lacking. So I don't know if we're going to achieve those targets. So in 2015, what have we done so far? In 2015, a group of organizations, professional organization along with GSK, we formed a Teal Ribbon Alliance and UACC, United Against Cervical Cancer. This included the Pediatric Association as well, and of Pakistan. And the Society of Obs-Gynae of Pakistan came up with a position statement, which is on their website as well, that HPV vaccination should be added to the API schedule. Pediatricians should add HPV vaccination to the list of vaccines that they are administering to the child's vaccination schedule card. They should further advise those girls and their mothers who are not vaccinated early, age 9 to 14, that they must get vaccinated before marriage. Remember, there's a gap when a little girl grows up and she's seeing a pediatrician, completing her vaccination. She's not likely to see a doctor unless she gets sick, maybe her family doctor. So her teenage years are basically unsupervised. And then they usually present to a gynecologist or obstetrician. after marriage when they're pregnant, or usually with an unplanned pregnancy because they don't get the counseling as well. So premarital consultation with a gynecologist or family physician is also to be promoted so that she gets health and contraceptive advice and HPV vaccination as well before marriage. Regular pap smears or liquid-based cytology or HPV testing or VIA screening should start after 3 to 5 years of marriage at 3 to 5 year intervals. And VIA training should be mandatory in postgraduate teaching hospitals. By the age of 30 years, if she's never seen a doctor, but by the age of 30 years, at least one pap smear or any of these tests should be done. You can stop doing pap smears at age 65 years if previous smears have been normal and no other risk factors are present. Create an awareness amongst general gynecologists, pediatricians, general physicians, family physicians, women, and in the general public. I think the government should also have campaigns, media campaigns where personalities, famous personalities should be advocating this preventive medicine strategy. However, stigma poses significant barriers to prevention. This is a topic not talked about. And we do have a EPI, expanded program of immunization in Pakistan, and we're offering so many vaccines, BCG, DPT, measles, Tdap is also now privately available. However, 11 antigens in 6 visits are being offered to children. However, HPV vaccination is not there, and it should high time that we should add it. Now, there has been advocacy. So even last year, even though we were really fighting and trying to fight COVID pandemic, JPIGO with Gavi funding did a landscape situation analysis and held advocacy meetings, webinars with stakeholders and the government representatives. It recommended in consultancy meetings for universal healthcare meeting with WHO, Ministry of Health, and other stakeholders. Sought meetings with concerned health officials after a preliminary virtual meeting for advocacy to include HPV vaccine in EPI schedule. Stigma in the minds of public and healthcare providers in cervical cancer are not talked about, and we need to talk more about it. The government cannot afford expensive vaccines, and however, we can apply for Gavi funding, but the will seems to be lacking. The challenges are that HPV vaccine is not available in Pakistan for over 2 years now. The COVID-19 pandemic has made vaccine procurement even more difficult while the government tries to cope with the pandemic. The HPV vaccine, the nonavalent, is even more expensive than the bivalent and quadrivalent vaccine. So it seems like a tall order. Universal screening is not being offered by the government, only opportunistic screening, both in government and private sector. The health spending, however, has increased, but it's still not enough. And after devolution of health to after the 18th Amendment, matters are even more complicated. What are the plans? So the stakeholders relevant to HPV vaccine introduction implementation in Pakistan are these organizations, as I already mentioned. We all have to work together. There should be federal planning, and everyone has to pitch in. But the government has to take the lead. We can only advise, we can do advocacy. We have pledged to do regular VIA trainings with the Society of Obs and Gynae of Pakistan and senior gynecologists, revive the Teal Ribbon Alliance of 2015, AMAN, which is Association for Mothers and Newborns, and the Society of Obs and Gynae have given permission for all concerned to use a sensitization video, which a real life patient volunteered to make, and it is available on their Facebook pages. to be used for anyone's advocacy work. It is a very good video of a patient sharing her own experience. The government should add HPV vaccine, the 9-valent, to EPI schedule. The health ministry in each province will be approached to do this and requested to add the vaccine to the school health program for girls. And vaccination should be given before they leave school, between the ages of 9 to 14 years, and definitely before marriage or nikah, if not already vaccinated. So the way forward is cervical cancer prevention trainings, both in Urdu and regional languages, with the PowerPoints and videos. A video of the presentation should be shared on official pages, and cervical cancer registry is really needed. It has been initiated by the SGP, but we need funding, and really it should be the government which should be funding this. Physical attendance at meetings remains a challenge during this ongoing pandemic. However, we have held many webinars and continue to do so. Awareness sessions should also continue for other healthcare providers, pediatricians, family physicians, medical and nursing students, and government health officials as well. The virtual and physical modality should be employed. So we need a government-funded health department media advertisement promoting HPV vaccination and prevention in the newspapers and on television as well. Possible screening solutions are self-care and a self-HPV test. This is easy to do, and maybe if provided by the government, women could do their own screening, and VIA screening. A single dose of the vaccine may be enough, but we have to wait for more data to come. But a one-dose vaccination campaign would be easier to implement than a multi-dose one in Pakistan. So I guess by the time we get it, we might be in the single dose category. However, most Pakistani rural women are poor and cannot afford expensive vaccines or screening or treatment. So we need more money to be spent by the government. In summary, HPV type 16 and 18 cause 70% of cervical cancer cases globally. The non-valent vaccine covers most of these oncogenic strains. Phase 3 clinical studies have demonstrated high vaccine efficacy. Vaccine efficacy and antibody response for the non-valent are found to persist at least for 5 years. Long-term observational studies are awaited. The non-valent vaccination can prevent up to 93% of cervical cancer cases, as well as other HPV-related anogenital cancers. Thank you very much.
Thank you very much, Dr. Sadia Hassan, for your excellent work in this arena of cervical cancer prevention. Being trained in the developed country and coming back and working in Pakistan, this sounds like an easy thing to do, but I can tell you, raising awareness and moving the public to get immunized is a daunting task. And I appreciate her efforts, and I salute her working in this environment where she has to face a lot of hostility, especially the lack of education, some religious elements are there, so many factors, but she's been working hard, and I have seen her working and trying to improve women's health in this society. We're gonna move on to our panel discussion, that is recurrent ovarian cancer and its treatment. We have esteemed panelists in our slot today. I can see some sleepy faces there as well. Dr. Asim Amjad, welcome you to this discussion. Thank you very much. I have already introduced Dr. Asim Amjad. He's a radiation oncologist from Canada. I briefly worked with him when I moved back to SKM. Great personality. Unfortunately, didn't have much time to spend with him. As I was moving in, he was moving out. I have my two esteemed colleagues and very good friends. I have Dr. Saad Jamshed, who's also an associate director at Rochester General Hospital. He is trained in DC and came back to Rochester General Hospital. He works for the Rochester Regional Health System, as well as Dr. Farhan Imran. He's also working in the same system. Both are trained hematologist oncologists. Usually the practice in US is most of the gynecologic oncology patients are dealt with GYN oncologists, and rarely they go to this hybrid approach, which is usually practiced in European system, where a gynecologist works closely with radiation oncologist and hematologist oncologist or medical oncologist for treatment. But in the US, it's gynecologic oncologist that is responsible for most of the stuff except for radiation. So for that reason, we have Dr. Khurram Shahzad joining our panelist as well. He is based in Moffitt in Florida. He's a trained gynecologic oncologist. He has delivered an excellent talk on advances in management of cervical cancer. And now that he has turned on his camera. And last but not the least, we have our distinguished guest and a panelist who is like a leader to us, an innovative guest. They say innovation distinguishes between a leader and a follower, as our famous Steve Jobs once said. So she is our leader here in SKM, Dr. Neelam Siddiqui. So every time we have a problem, we get back to her and collect our pearls from her. She's going to join us in this talk of recurrent ovarian cancer, which is always a challenging disease to handle. And I'm going to start with this case presentation, and then we're going to lay the grounds and then discuss the innovations and obviously the current treatment for recurrent ovarian cancer. Most of my panelists today are joining us from either Europe or the US. You guys have to understand we are working in Pakistan with the limited resources. So you might not have heard or practiced according to the European or American standards. For the most part, we are working according to those standards, but the innovations we usually see in the West are not here as yet, like, immunotherapies and whatnot. So we're going to be talking about those. And we sometimes feel that once we have those resources available, we're going to be a part of that family as well. So here's the case we usually encounter in our tumor board. 54-year-old nulliparous, diabetic, hypertensive, well-controlled on meds, diagnosed with advanced high-grade serous carcinoma back in April 2019. Her initial CA125 was 3,300. She underwent debulking surgery in April 2019. It was an optimal debulking, and then started on carbotaxol, which is the standard treatment, IV carbotaxol, and that ended in October 2019. She was disease-free for almost a year or so. CA125 normalized until recently. She started complaining of abdominal discomfort, bloating, and on imaging, she was noted to have mild ascites and diffused carcinomatosis. So the question is, what next? Before I go on and we start talking about the recurrent ovarian cancer for our attendees, where we have a lot of fellows and residents, ovarian cancer is the second most common gynecologic malignancy in the developed countries, second to uterine cancer. And as I said, it's in developed countries. We have a bigger load of uterine and cervical cancer in Pakistan as well. So most of these ovarian malignancies, 95% are basically epithelial origin ovarian cancers. and subtypes like high-grade serous, low-grade serous, endometrioid, clear cell, and mucinous. And then if you look at this, look at the data, an average female has 1.3 or 1.5% risk of developing ovarian cancer. And 18% of these epithelial ovarian cancers are associated with germline mutations, basically BRCA or BRCA1 and 2. And that is very important down the road as we're going to be discussing the treatment. Mostly people associated with Lynch syndrome are likely to have non-serous EOCs. So when we define recurrent ovarian cancer, we talk a lot about platinum-sensitive disease versus platinum-resistant disease. When we look at platinum-sensitive, what we define as, in gynecologic oncology is progression-free interval of 6 months or longer are considered chemotherapy-sensitive disease after platinum-based chemotherapy. And same thing if it's less, if the patient has recurrence or relapse before 6 months is considered platinum-resistant disease. And patients who actually develop progression during the first 6 months, they are sometimes labeled as platinum refractory disease, but they're usually treated as platinum sensitive disease most of the times. So, a decade ago, the therapy actually from IV, we changed to IVIP in developed countries after a landmark GOG 172 study where Deb Armstrong presented the data that after optimal debulking, IVIP chemo is very strong in improving OS and PFS. And later on, GOG 252 actually summarized that if we add bevacizumab or Avastin in the IVIP chemo versus IV chemo, there's no big difference. So, a part of our group suggests that IV chemo with Bev is equally good as IVIP chemo with Bev. And then, it was also proven or actually showed in phase 2 OV21 trial that in a neoadjuvant setting, IV versus IVIP chemo is not different. So recently in SOLO-1 trial, we realized that, and I'm talking about purely primary ovarian disease. I haven't talked about recurrent disease. For that, I have these esteemed guests to talk about that. And we're gonna move towards the new innovative treatment options. We have realized recently that immunotherapies and PARP inhibitors, in addition to bevacizumab, is remarkable in treating primary ovarian disease and has changed the horizon in that situation. Coming to a relapse, we all know that 80% of our patients who attain clinical remission after the initial therapy, out of those 80%, 80% of these patients relapse within 3 years. And that's daunting. That tells us that we need to do a lot of work in it. And it does not depend whether this is platinum sensitive or platinum resistant disease. So the average survival after the treatment of recurrent disease is less than 10%, very, very dismal. And that tells that we need to do a whole lot of work. And recently, when we saw the Desktop 3 trial and SOC or SOCR1 trial, we realized that, yes, there is promising results, and we'll be able to see those promising results soon as we are moving on. So especially the innovative techniques like immunotherapy and PARP inhibitors, checkpoint inhibitors, we see a lot of promising future. So let's open this discussion on, especially, I'm gonna ask Dr. Khurram Shahzad about the surgical management of recurrent disease. That is probably, the confusing part of this. Half of the times, or we don't have concrete data on this. So what's your take on this? Thank you.
Thank you so much for inviting me for this discussion. So it's actually interesting topic. So we used to obviously take patients back for secondary debulking surgery. That opens up another question, which I'll cover later, but we used to take patients back to a secondary debulking surgery and then give chemotherapy until we have the recent GOG trial that came out with and without bevacizumab for recurrent ovarian cancer patients who then underwent surgery. So in a nutshell, unless there is a single place local disease that you can go ahead and resect, it's one or two areas, you can do surgery. Mostly the systemic treatment is going to be offered to patients. How many times have I taken a patient in the last 10 years? 0 time, almost 0 time, unless if they had a bowel obstruction. So if there is another reason to do surgery in the recurrent setting, then that would be the reason to do surgery, but not for debulking. Most of the times when there is a recurrence, if you see something on a CAT scan, that's not the only disease that's there when you go to actually remove disease. And if there are multiple sites, in my own view, I think our center does not take the patients back for secondary debulking.
So you just mentioned GOG 213. And when you look at GOG 213, that was, and go back, that probably came out in 2019. And then the recent trials like Desktop 3 and one of our SOC1 trial, that actually, butting heads with 213. So being a gynae oncologist, surgically based specialty, how do you see those results?
I think we have a lot of options. When these trials were started, we did not have a lot of the genetics information in the picture. We were not differentiating between BRCA patients. Bevacizumab maintenance was not in the picture. So now you have PARP inhibitor maintenance up front, and that's giving you 21 months of recurrence-free survival. You have bevacizumab maintenance. You have a trial showing combined maintenance. So the treatment is changing so fast. The Desktop trial is there, but that's still not, I think, for us enough to start taking the patient back for a full-fledged debulking with multiple areas of recurrence. Yes, if there is one site or two sites, or maybe up to 3 sites of recurrence, but it's with a prolonged recurrence-free interval, then maybe that can be considered. But in a situation where you have a BRCA positive patient, or HDR is positive, or LOH score is greater than 16, you're probably going to be thinking about starting PARP inhibitor even in the second line in those patients.
So when you take these patients back to the OR, do you follow any criteria like, Memorial or AGO or TION? Do you have any specific, criteria in your mind when you're looking at these patients?
We actually don't take them back. So like I said, in the last 10 years, I've taken 0 back just for secondary debulking sake, but we are 61 oncologists here. So one of them has taken 1 or 2 patients back. It depends on patient's health situation, what else is happening, their age, the location of recurrence, how big the surgery is going to be, and if they're going to get back to chemotherapy within 3 weeks of surgery. And if that's not happening within 3 to 4 weeks, and you're done a big 8-hour debulking surgery, then probably you're not helping. So
I'm gonna go over to Dr. Neelam Siddiqui, who's been here for quite a long time, and she has seen the ups and downs of this institution as well. So what is your experience here at SKM?
Yeah, I think, thank you. That's what I wanted to say, that Shahzad, you're right, that things are changing. But I think this particular study, Desktop 3, is really relevant to our setup, because none of our patients would have had, like solo 1 or solo 2 options, and the majority don't get bevacizumab unless they are paying. So very few of our patients would be getting targeted therapies even in this time because of the cost, and because we're treating a lot of patients the numbers are huge. So, we have to focus on giving same sort of therapy to all the patients, but a bigger number of patients. So desktop 3, because Rehan knows that in ovarian conference, I'm always sort of mentioning that, because I think it's a very relevant study, and with the fact that all the patients who'd had surgery in the past and had complete surgery, and if they had relapsed with more than 6 months of interval of without chemotherapy, so platinum-free interval of more than 6 months. And the good thing about desktop 3 was that they had a very good, well-defined criteria. And that was that patients, they had AGO score positive. So ascites was less than 500 cc. And they were, it wasn't like this patient that just had multiple peritoneal nodules, but if it looks resectable, ECOG performance data is 0, there was overall survival difference. So patients who had cytoreductive surgery upfront compared to chemotherapy, which we would give to these patients most of the time, there was a difference from 43 months to 53 months. So that is relevant, I think, more in our setup. And yes, with BEV availability, that can sort of, muffle the results. But still, we need to keep that in mind when we are discussing the patients. Because we used to wonder, we did quite a few patients for cytoreductive surgery at first relapse, but now this gives us confidence that we should definitely consider that for our patients when we are discussing relapse cases.
So interestingly, Saad and Farhan work in a very hybrid system in Rochester, New York. They are in collaboration with the Gynae Oncology, where the Gynae oncologist does the surgical part and they take care of the chemo part. So they are working in sort of a European model, so to say. So I'm going to go back to these two individuals. So Saad, what was your take on this?
I haven't seen patients going back in our institution for a second debulking procedure upon relapse, partly because our standards of care might be different, especially incorporation of bevacizumab maintenance and the efficacy of that. And I mean, in this case in particular, we would have wanted to know the BRCA status or HRD status and the MSI status of the patient too, probably at the time of diagnosis, if not at the time of relapse. To help guide what subsequent therapies we would do in terms of maintenance. Looks like the patient had optimal response. Platinum-free interval was more than 6 months. So going back to platinum and taxane for 4 to 6 cycles to get to a remission would be the right approach in this case. And then strong consideration for maintenance to see how long of a remission we can get if she is responding to treatment.
So
that's right. I think when a patient comes with relapse, you're very right. We're just because the aspect of surgery, Rehan asked, but you're right that, like even newly diagnosed patients, it's now recommended they need to have the BRCA testing done. And so most of the centers in US are doing both germline as well as somatic, but it is recommended now for all epithelial ovarian patients. But if a patient comes back with first relapse, the things to consider are, first of all, how long the period of platinum-free interval, even before that, the histology of the tumor. Because that's something we used to treat all ovarian cancers as same, but now it's becoming very clear that there are different types of ovarian cancer, type 1 and type 2, high-grade serous and high-grade endometrial are type 2. And the others are like clear cell, mucinous, and low-grade serous belong to the type 1. So they behave differently. So we need to know the histology. We need to know the biology. We need to do the genomic testing. And then platinum-free interval, patient's performance status, symptomatology. If a patient is just incidentally discovered to have relapse or she is very symptomatic, then you would take the patient accordingly, and patient preferences, of course.
I can't let Asim Amjad sit quietly for a long time. He's been sitting in, I hope, in Canada. Not sure if Canada or England. So Asim, what's your take on this?
I think my take is, as Shahzad was saying, that I can't remember the last time any of our patient was taken to theater for second line cytoreductive surgery. It's a very hard thing to do. Even in the trials, you see the patient's criteria that were taken to dependent on their ECOG performance status, less ascites and huge cytoreduction previously. Those criteria are very difficult to achieve when they have recurrent disease. And fibrosis and adhesions and all that makes it almost impossible to have a meaningful surgery for these patients.
So moving the gears a little bit, I'm going to move to Farhan. So what about these PARP inhibitors? How much are they helpful in this disease now that we are seeing a lot of these PARPs and coming up, TKIs and whatnot?
So thanks a lot, Rehan. Before I give you my answer, I would like to thank you because since Saad and I are from your home institution in the United States, after your fellowship in Dartmouth, the whole Gynae department dearly misses you, and especially your patients. So warm regards from over here. And thanks for inviting us in the midst of such big minds from across the globe. So before I say a few words about PARP inhibitors, may I just add my opinion on the previous discussion that I was hearing. Since we are medical oncologists by training, we do not have surgical training, but we take care of a number of other cancers as well. So we have the additional benefit of drawing analogies between other solid tumors, such as lung cancer or breast cancer. And I know each cancer has a different data, but at least your approach is learned from one cancer and applicable to another as well. So recurrent ovarian cancer is one of the few solid tumor cancers where even in metastatic relapse refractory setting or upfront metastatic setting, cytoreductive surgery is done. In many other solid tumors, it's not even considered because it's considered palliative or stage 4 or incurable disease. So when a patient has a recurrence, like you mentioned, in a patient like yours, of course, we want to see whether it's only a biochemical recurrence with CA-125 elevation versus actual bulky disease. In the United States or Canada and Europe, where these are more resource-rich countries, we have a lot of tools that we can use, which includes all the testing and which includes microsatellite stability status testing, which includes germline and mutational testing. And nowadays, we have something called Foundation 1 testing, where we can test the tumor for not just 1 or 2 mutations, but a broad range of mutations. And that sometimes comes up with additional targets which are out of the norm. So for example, if a patient has an ALK mutation or an EGFR mutation, so sometimes you can use a drug tailored to that if insurance would cover. And then bevacizumab data came along. We have the PARP inhibitor data. So we have so much to do, so many tools at our disposal, where we start with platinum agents, then we have single agent, old school chemotherapy, we have PARP inhibitors, we have bevacizumab, we have immune therapy. So even for stage 4 advanced incurable disease, we can continue offering treatments for quite a long period of time if quality of life is maintained. So for that reason, also taking a patient back for surgery sometimes does not make a lot of sense. But me as a medical oncologist, I do not make that decision. I always get my gyne oncologist to evaluate the patient and see, based on their clinical surgical expertise, what can they offer. It's another story that a lot of times these patients may not be ready, or they may not have enough of a clinical status to undergo such kind of surgery anymore. But I always get an opinion. So that's where I was hearing Dr. Siddiqui mentioning that some of these surgeries are still done. because I would imagine that a patient who is not able to spend all that money in Pakistan, they may not have a whole lot of other treatment options. So that's where my mind takes me. In terms of PARP inhibitor therapy, definitely we have used it a lot. The agent that I've used the most is olaparib, but as you know, there are others as well. And then basically, they definitely add, there's survival data, progression-free survival data. And if a BRCA1 mutation is found, then definitely we are adding that as a therapy, and we're seeing responses very well tolerated as compared to chemotherapy. We definitely have some cytopenia, some myelosuppression, but it is nowhere near as severe as with chemotherapy. And even wild-type patients for maintenance, we have used it. And patients with biochemical recurrence or patients who have had the disease in remission, we have certainly used PARP inhibitor therapy, and it is very much being used. So these were a couple of comments that I wanted to make on the previous discussion.
So, Dr. Shahzad, are you putting your patients on Avastin for relapse patients? Avastin and PARP together, or you're doing PARP alone? How are you treating your patients?
So it's actually very funny how the companies design their trials. Initially, they wanted to assess the patients who have BRCA mutation and show there is a difference, then include the HRD patients so they can get a bigger population. Then do a study which had significant number of BRCA positive patients and not do BRCA testing and say, well, you should offer this to everybody without testing. That's very good for the company. But when you look at the results, patients who don't have BRCA-ness, they don't have BRCA1 or 2 positivity, they don't have any of the BRCA partner genes which are elevated, they don't have LOH, loss of heterozygosity, or they don't have the HRD. Those patients are not actually benefiting. But when you put them in the pool of everybody else who had BRCA or BRCA-ness, those patients benefited so much that it kind of skews the result towards them. So normally, if I know somebody does not have BRCA mutation, we do foundation 1 testing because 15% of patients who don't have BRCA mutation in germline, they may have a somatic mutation. So if they don't have somatic mutation, and they don't have BRCA-ness type of picture, there's no HRD, there's no LOH that's greater than 16. I'm not putting those patients on a PARP inhibitor and then actually giving bevacizumab preferentially to those patients because that option is available. A patient who has a BRCA mutation, they had upfront debulking surgery. Once they finish their chemo, they will be on a PARP inhibitor because you have a 21-month plus benefit for that. And then I would save bevacizumab for later on, maybe for secondary recurrence when I need to use.
Okay. Dr. Siddiqui, in our setting where we have limited resources, and I'm not sure if the hospital can support Avastin yet, or is the patient doing it out of pocket? I'm not clear about that though. So what do you do in this setting?
So, you see, I was just listening to everybody. I was talking about our supported patients. But if a patient is able to afford, so we do get, germline BRCA, now the hospital is offering to all the patients. So we do get it done. Obviously, you could ask that why get it done because you don't have PARP inhibitors, but still, I think it gives me a lot of information about the biology of the disease, as well as, especially in a new patient, if somebody has got early stage ovarian, and I know this is BRCA positive, then the whole genetic counseling and prevention for breast cancer and all. So we do have the tests available. However, because we don't have PARP inhibitors at the moment, they're extremely expensive still. With time, we are hopeful that they will get cheaper. So if a patient who's not able to afford, obviously I would offer platinum again, because that's the most important chemotherapy agent in this patient. I think your patient that you said has probably got about 18 to 20 months of disease-free or progression-free interval.
Right.
So I expect her to be very platinum sensitive, so and combination. And liposomal doxorubicin, if available, I could use that with so the different combination. Platinum sensitive is really very relatively easy to treat and very rewarding. So I do have patients like multiple lines of chemotherapy, whatever we have available, we sort of, so I would give a combination. Even you could give carbotaxol, carboplatin, gemcitabine, carboplatin, liposomal doxorubicin is better tolerated. If affordable, I could use that. So platinum combination in a platinum sensitive disease. However, if a patient is affording, then we do get foundation tests, like to send the tumor for somatic testing. And many of my patients are on bevacizumab. So they get first line as well. We follow the GOG 218 module or ICON 7. And because especially in the ones who have advanced stage 3, C or 4, we know that there's overall survival benefit as well. So a patient like this who had only carbotaxol comes with first relapse. As Shahzad, I think, said that we would do BRCA testing if a patient is BRCA positive. Then obviously then there are several trials, but Solo 2, Nova, and I think the other one was Ariel trial. So these are different PARP inhibitors, but they have more or less the same efficacy, and hazard ratios were from 0.23 to 0.3. So really good progression-free survival benefit and overall survival benefit as well. So if I have the money, I would definitely, after giving platinum-based chemotherapy, then would give maintenance, because things are totally changed in ovarian cancer. So, like from 2018 and 2019 ESMO, when 3 PARP inhibitors trials were announced, and that was probably the first time ESMO, there was so much excitement about a gynae oncology sort of topic. Normally it's the lung and breast and other. So I can't forget that ESMO, that was practice changing. So obviously it's in our setup, we just whatever we have, we try to do our best. But because we have PGs and fellows also watching. So if it's not a BRCA mute or HRD is also very important. So if HRD is negative, then you could follow the OCEAN module of bevacizumab, that is platinum sensitive relapse. And so you combine, they use carbogem and bevacizumab, but there is a study of carbopaclitaxel and bev, which is probably better. So you could do that. The problem are the ones who are platinum resistant or refractory. They are really frustrating to treat.
See, I told you guys that she's the queen of wonders, working in this limited environment, playing with different chemos. I'm going to change the gears to, we have so far discussed platinum sensitive relapse. Let's change gears to platinum resistant or platinum refractory relapse, which is usually treated with single agent. So what's your experience, Saad?
By the time, so first of all, thank you for inviting me to be part of this esteemed panel. So thank you very much. Going back to the question at hand, platinum refractory disease is difficult to treat. These patients have a lower chance of response to therapy, unlike platinum sensitive relapse or upfront disease, and the duration of remission is also much shorter. So depending on how the performance status holds, you may be able to cycle different chemotherapy agents, presuming you haven't used a PARP inhibitor previously. If you have, then if in somebody who has BRCA nest-like disease, you could even consider a PARP inhibitor. Chemotherapy options, they are different and many. If you haven't used Doxil, or liposomal doxorubicin, the schedule for that is very convenient for the patient, because some of the other treatments are once a week and the patient is coming in very regularly to be treated. So chemotherapeutic options wise, it would be gemcitabine, liposomal doxorubicin, other taxanes. Weekly taxane can be considered too, presuming they haven't had significant toxicity from prior taxanes, Taxotere. If they go further along and become really refractory, we have had some patients on oral Cytoxan, If there is ascites, we typically continue bevacizumab, presuming they haven't had perforations, haven't had a blood clot or hypertension or other toxicities from it, because it does do wonders in terms of recurrent ascites, because it's all about quality of life at that time. Despite continuing treatment, you want to make sure that patient stays functional and they are able to maintain a reasonable quality of life, dealing with a disease which will ultimately take their life.
What do you think?
Obviously, platinum-resistant disease, I think this is where if we make a difference, we'll add a lot to women's lives. It's a difficult disease to treat. Once it's platinum resistant, we're behind the ball game. So I normally would follow the Aurelia trial for the first recurrence when the patient comes back and do, from Aurelia, they had the comparison with a combination of topotecan. They had weekly Taxol and Doxil with or without Avastin. So, with Avastin. So there they found that patients who actually had topo likely had the highest results, but topo also had a lot of side effects. So I compromised that with a weekly Taxol with Avastin as my first preferred and save my Doxil for later on. And that's why I don't use Calypso trial in the first recurrence to give carbodoxil to those patients when they're platinum sensitive, so I can save my Doxil for later on when they're weaker and probably as my last chemotherapy before moving on to, some other combinations or clinical trials. So weekly Taxol with Avastin for platinum-resistant disease, I think that's my first choice. And then depending on the recurrence or clinical trials which are available. So many times we'll have a clinical trial that patient can get on and probably get us another year or 6 months before I need to reconsider. Sometimes the weekly Taxol combination, I've combined it with Pembro in patients who just could not have surgery, multiple blood clots. They were prone to have a platinum-resistant disease. And I have one particular patient right now, it's been over a year. We were discussing hospice a year ago, and today she's doing well and functional. It's a weekly Taxol with Pembro, but this is because we ran a clinical trial, which is not published yet, which actually shows equivalent results compared to Aurelia. So that's another option that's available. Other than obviously hit and miss in some patients, Cytoxan with Avastin, sometimes you can get a year out or 6 months out in some patients, and really you get surprised.
Right.
If you don't have Avastin, then like oral etoposide works very well, about 27% response rate. So we use that quite a lot because it's cheap and it's easy to give. So, but it's interesting, Pembro and weekly Paclitaxel.
Not to take everyone, I guess, away from the topic,
but
I wanted to.
They don't have Pembro. But it's interesting because there is a trial of Pembro, PARP inhibitor, and chemotherapy. So this one, yours is sounding quite good. I hope we get some good results.
What I wanted to say was we mentioned the desktop study, so I didn't want to get into it too much, but I think this is the right time. If you do a good surgery, those patients had a great overall survival benefit for maybe about 12 months, I think. But patients who did not have a optimally debulked surgery to R0, those patients had 28 months survival, which was worse than the patients who didn't have surgery. And these survivals that you're seeing are, showing benefit are at high cytoreductive rate centers where like MSK is going to have 80% of their patients optimally debulked. So when a patient goes to that center, we'll have better results compared to maybe a different place or a private surgeon who's doing a surgery will be a very different result. So those things should be considered because that will lead to platinum resistance eventually. And then you are stuck with, some of the things that we're talking about now. So
that's the story. That's the story of our life. You can very well imagine, Khurram, that you've been coming here, off and on. You can see that that's what we have to deal often. My organizers are actually waving me that we are a few minutes over now, but I really don't want to stop here because this discussion has been so interesting. But in the essence of this organization, this opportunity. I wanna thank you all, especially people who have joined us from outside Pakistan, especially at these odd hours. And I didn't realize this morning the clock actually changed in the US, and I had to call Saad and Farhan to make sure that they're not gonna be sleeping through that. And Asim, thank you very much joining us. We are waiting for Khurram Shahzad. Khurram is gonna be joining us for, inshallah, citywide grand rounds in January, late January. I haven't finalized the day yet, but for sure within a week or so, we're gonna be finalizing that specific day, and that's gonna be a great opportunity for us to listen to your innovative thoughts and your current standard treatment practices. Dr. Neelam Siddiqui, as always, you've been a great support for us in this department. Thank you very much. And I thank all the organizing committee at this point who has given us an opportunity to listen to these esteemed colleagues from across the globe. Dr. Asad Pervez, Anika Agha, thank you very much. And you guys have a beautiful evening, day, or whatever the time you have. I thank you very much for joining us. Ciao.
Thank you, Rehan. Thank you.
Thank you.
Thank you.
Bye. Good to see you, Asim.